This is a wonderful site. Over 300 people from so many organizations and so much expertise and work in this area. Really thrilled to be here and to be part of the group that helped to bring this together. Great, so I'm going to talk a little bit about this tagline that was in the title of the Open Digital Health Summit, full stack, and what that means to this meeting and how. Okay, great. Thanks. And how it complements the work that I think we are all collectively trying to do. All good? Great. So in our experience as WHO, and we've been looking and understanding and working with countries for many years, and we've come to realize that many of the goals that countries have are really about digital transformation, not for a single health domain area or a single goal, but rather it's a collection of objectives in the health sector. And those include, for example, ensuring and getting to a point where there is an established personal health record for everyone. That quality and continuity of care and health workers have access to up-to-date protocols and patient history. That financial planning and protection for health system users is across the entire sector. That there are no more stockouts, and digital is helping to complement that. That there's timely pay, proven skills, continuous growth of the health workforce. And that responsible AI is utilized, is safe, effective, and locally appropriate. And lastly, areas such as timely detection, assessment, reporting, and action for public health risks. These goals are ones that cannot be solved by one single solution, but rather require a coordinated, orchestrated approach that really is at the heart of the work that we're pursuing here. If we look at the example of immunization, we recognize that there are a number of actors that have to coordinate around ensuring that a child receives their 2 vaccination doses for DPT. For example, there's a need for a reminder to the household to ensure that they're aware of and that they know that they're eligible for their first vaccination dosage and that they've been registered into a system, to ensure that that individual is then recorded in the system and that is part of a child health card with her patient ID, to ensure that at 2 months later, the mother and child are sent an SMS or the health worker is reminded to ensure that the child receives their second dose of DPT. At the health facility, the nurse would need to locate the immunization record with the patient ID and would need to ensure that the health facility's record system is interoperable with the National Immunization Campaign Registry and a number of canonical registries, and that they would need to ensure that that patient is both eligible and then has also received that vaccination to ensure that they then receive their second vaccination dose. Unfortunately, this ideal is not yet a reality, and we're just using the example of immunization. We could have looked at TB, HIV, we could have looked at any health program area, but oftentimes, instead, unfortunately, many of the systems that are in place at a very simple level are not able to communicate and exchange data with another system. This lack of interoperability is inhibiting the ability to ensure that every patient is recorded and that they're able to follow over time and ensure that they're able to fulfill an entire dosage, but also that the systems that are required for logistics management and the systems that are required for reporting are all able to effectively work together. This collection of systems need to function in a coordinated way. And oftentimes, unfortunately, in a lot of countries, that's not yet the case because of these gaps in the interoperability standards and the inability of those systems to then communicate and exchange data for a common purpose. The Global Digital Health Monitor, which many of you will maybe have seen and also have used to assess the capabilities in your own country and work to define a path forward to improve the maturity of the capabilities in your country. Just looking at the 7 building blocks across 4 of the WHO regions, we looked at some of the indicators that were in that to really assess to what extent are the enabling components of digital transformation in place. And these 6 different elements are reflective of the country's preparedness and capabilities to be successful with digital health. While many of the countries have digital health in their national plans, a much smaller proportion of these countries have specified allocated funds for digital health or an architectural plan that includes an information exchange, such as in the purple bar, or the aspects of registries, canonical listings of health workforce, patients, and providers. These components, including the use and adoption of interoperability standards, reflect on the fact that there's an intention through the fact that there's a national strategy or that digital is in the health strategy, but the operational elements that will be required for digital transformation are not adequately available across countries, across all the regions. That doesn't mean that there aren't countries that are succeeding in this area, but that there's perhaps inadequate attention to these foundational components. Just looking at 2012, a long time ago, it was over 13 years ago, and looking at Uganda, which at the time, many of you will have seen this slide, but it reflected a period of time where there was a lot of experimentation and there were a lot of pilots that were really about demonstration of to what extent these individual solutions might be able to achieve and help a country to address individual or a collection of problems. This commitment and intention of the government to ensure that there were a number of different digital systems and they were able to effectively come together, they began to realize that this pilotitis situation, this lack of solutions that were adequately able to scale was a problem that they needed to use the governance and their policies to be able to institute a moratorium on new projects. They used that opportunity as well to start to build the governance around what would be required for Uganda to have a national plan, a national strategy, and the coordination necessary to move that forward. Many other countries in the region were doing the same thing and starting to pursue national plans. The reality is that while there's been progress, this work that the Gates Foundation did in 2023, looking at the outcomes of the pandemic, actually looking at work that Digital Square and USAID invested to look at the mapping of investments in digital for the pandemic response, reflected on the fact that many of the solutions that were being used were not being used at national scale or not being reused. That inability to make use of those systems for a new problem area was in some ways a reflection of the fact that there was a continued investment into siloed solutions, not solutions that could be utilized for a diversity of purposes within a national ecosystem and using standards. In the introductory chapter of a WHO document called the Digital Implementation Investment Guide, we illustrate a number of different architectures. And I don't know if it's readable, but we articulate that there is an example of a siloed architectural approach, and it typically focuses on a project, utilizing a product, and really it's a time-bound set of goals to be able to demonstrate that something is functional. Oftentimes a country may start to utilize that same solution and begin to augment that solution with additional capabilities adding new functionality, whereas the original solution may not have been architected or thought or designed in such a way to really reflect on the diversity of needs that would have to be utilized. And this idea of a mud architecture, or something that's agglomerated and isn't really well thought of, is something that often creates this challenge of technical debt, which the expense and the technical challenges to overcome a large number of these solutions, or a single solution that is trying to do it all, is something that many countries face without really thinking through and planning a broader architectural approach. This integrated approach that is perhaps thought of as maybe more of an advanced approach, where you're trying to connect two different solutions together, while seemingly valuable from the point of view of connections, once you begin to have a number of different solutions in the ecosystem, it becomes untenable to financially manage all of the integration points that are necessary. And this is why interoperability standards and architected approaches, as illustrated on the diagram on the far right, is something that can help address the health sector goals. And this is not something that's perhaps new to everyone, but I just want to illustrate the point that we have to think about, and I think many of you, all of you in the room are doing that already, but that we need to also think about how do we bring ourselves out of technical debt that may already be in the ecosystem. So we're at a unique turning point, a tipping point, I think, from this point of experimentation and fragmentation to a point of transformation. So how do these different components that are important in the ecosystem, you'll hear more about the digital public infrastructure at a foundational and a health system level, but also the use of standards. How do those components come together and help you in the health sector be able to deliver on the diversity of needs that you have? And I think we're at a unique juncture with promise and opportunity due to a number of factors, in fact. And I'll talk a little bit more about those. I want to just maybe comment on the fact that other sectors have seen successful digital transformation in a very substantive way, and those include, and I think many of you are benefiting from a lot of the areas that Alan noted in his speech, but the areas of banking, transportation, and education, where not only do you have public demand for that, but you also have political will combined with the digital infrastructure that has made it possible for each of those sectors to really succeed with, for example, digital payment systems, digital ticketing, and the use of applications and certification tools to be able to ensure that there is, for example, transportation and ride hailing that is possible with real-time tracking. The uses of digital and internet connectivity at schools, and that really the demand is coming from consumers, parents, patients for a transformation also in the health sector. And I'm happy to say that there's a public demand that has emerged very much from the experience during the pandemic, where people had experience with telemedicine. They had and have experienced both with the challenges of continuity of care, of having to re-record to each facility their patient information and their demographic information or patient history, to also the aspects of there is a need for inclusion across the benefits of digital for the entire health sector, and really ensuring that the benefits are equitable and that the design takes that into account. The demand is clearly there. Similarly, the political will. Digital transformation is high on the political agenda, as demonstrated by national and global level actions and political commitments. The governments have been documenting their vision in national digital health strategies, emphasizing and linking architectural approaches, policies, and standards, and to bring their strategies to life. And the global strategy that was authored by 194 WHO member states and represents a collective commitment to a set of actions and objectives. And lastly, the UN Global Compact, which brought together all the UN agencies and 194 countries that authored that document, and emphasizes the cross-sectoral needs for digital to benefit all, and highlights the importance of using standards in digital public infrastructure. I just want to note a little bit about the political commitment in digital health. And in the Global Digital Health Strategy, which many of you, I'm sure, are very familiar with, the Global Digital Health Strategy, the language focuses on the aspect of person-centered systems and focuses on how we can ensure that we use reusable digital health components alongside open standards, alongside the use of shared services to achieve the health sector goals. And this was enshrined in the strategy, and very much being authored by 194 member states is a reflection of the vision that is already there. Within the digital infrastructure third leg of the stool, if you will, I want to just comment a little bit on this aspect of, within this area, we called out the idea of full stack, and I'll just talk a little bit about what that means. It means open standards, open technology, open architecture, and open content. And these 4 different components make it possible for what was in the vision of the Global Digital Health Strategy, which is person-centered care that benefits everyone and is available as a set of different digital tools to benefit all health programs as well. This really reflects on a set of components that have come together and made, we think, it possible for acceleration to happen between the different actors that need to come together to bring digital transformation to life. So open standards being common schemas and APIs to promote exchange of data. This interoperability is something that's possible using open standards that are free to use and community driven, such as FHIR, that you'll hear more about, and I'm sure many of you are already using and have a goal to achieve, and the use of ICD as a semantic standard, alongside blueprints that describe the diverse interconnections of systems and capabilities, for example, OpenHIE and IHE, alongside open technologies. This is open source tooling that supports the development of standards-based products, platforms, and solutions. For example, digital public infrastructure, open health stack, GovStack, the work that ITU is leading. Alongside open content, the authoritative public health and clinical knowledge that can be encoded into digital platforms and drive evidence-based, high-quality, person-centered care. For example, the SMART guidelines, I think you've seen, we have an immunization version of that that we've made available out in the outside. I want to go a little bit into DPIs, and not with a lot of explanation, but just to acknowledge the fact that health sector cannot go at digital transformation alone. We've realized and recognized that over 20 years, that the benefits of digital transformation are happening across all sectors, and there are common elements that we can all benefit from. We all need connectivity, we all need power, we all need devices, but we also can benefit from services that are common, such as identity, data exchange, financial services, that then make possible the health sector specific DPIs, such as a shared health record that benefits from the underlying components. And then applications on top of that are then able to utilize common standards and the DPI infrastructure that underlies that. This is just a simple slide, but it does reflect on the fact that there is a growing movement around this area, alongside the work that Google has very kindly provided to the global community around a set of tools and code that people can then build on top of and build their own entire stacks or their own applications. But the unique aspect here is that they've built FHIR into how they've identified the code base that would help accelerate those who are developing solutions. Also, I'll note GovStack, another example where a number of different services have been identified and brought together and are then able to be brought together on the DPI foundational stack or the DPI health stack. And the last example I'll give is the open content. This is really the documentation, the requirements documentation that make it possible for anyone who's developing a software product to know the capabilities that should be in it, the minimum data sets, the workflows, the performance indicators, the calculations alongside the interoperability standards that are encoded in open standards and are also defined in a way that can then ensure that regardless of which software you're using, it can function and calculate information and run algorithms in the same way. And here are some examples of smart guidelines. And WHO is not the only group developing smart guidelines. There are a number of agencies, including CDC, NHS, and countries like Kenya that are pursuing this as a documentation approach. I just want to note that digital health, the revolution requires shared responsibility and action from all stakeholders to realize its transformative potential. For governments, the role of national leadership in driving alignment with full stack principles and accompanying policies, architectural investment plans is critical. Procurement policies enforcing interoperability standards and governance frameworks and the services that make the ecosystem function is going to be critical. For donors, driving a shift towards funding to foundational components such as national registries, shared records, and capacity building initiatives, alongside the technologists engaging with open source ecosystems and contributing to open interoperable digital health tools is going to be foundational, alongside private sector innovation within transparent and standards-based marketplace that link to national digital infrastructure backbones and insurance schemes is going to be a game changer. Bridges, like the one on the left, can be built to solve simple problems with simple strategies, but to transform an entire health sector alongside other sectors requires planning, coordination, and above all, a vision of collective action. The full stack approach alongside FHIR, ICD, and DPIs are critical ingredients along an important pathway to achieving the vision outlined in the Global Strategy on Digital Health and the Global Compact, making possible effective planning, collaboration, and sustainable digital transformation. Thank you so much. I'll invite Hani Eskandar from ITU to join me.
Yes, thank you very much and good morning. Let me first share a personal reflection because as ITU, we've been involved with WHO since 15 years or more. And today for me is almost a dream. Why? Because I see that we as an ecosystem is really changing our narrative. I mean, the presentations that just delivered by Garrett really witnessed this. Many of us, we've been involved in digital health since many, many years, and I think the narrative today is very different, which shows that there is some maturity. And actually, you know, the concept of DPI is not really new. I mean, in 2020, ITU and WHO published a handbook called Digital Health Platform. And I see some of the authors even here in the room. We started this in 2018, 6 years ago. We published it in 2020, unfortunately during the pandemic. I must say this publication didn't attract any attention. And I was very disappointed because we spent like 2 years developing it, and it is still to a large extent valid. Of course, it needs to be updated, but we were trying to explain that there is a need for a common shared platform, shared services, and why and what are the components, but it didn't get any traction. And it seems that the health sector was not yet ready. Why? Because people didn't see, or maybe, and I'll try to be provocative here, maybe people and partners and countries thought that by innovating, they are doing digital transformation. This is they were thinking they were doing the right thing. I am going to invest in putting this solution here and there. And unfortunately, till today, till yesterday, I heard about a discussion from a country, oh, let me use this solution to solve this issue. Let me solve this solution. They are trying still to solve small scope solutions, and they are thinking they are doing digital transformation. Unfortunately, the link is not, innovation doesn't equal digital transformation. And this is maybe the first takeaway I would like to get from my little speech. Why? All the 7 use cases that Garrett showed on the screen, you know, the access to a personal health record, the continuum of care, the supply chain, blah, 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 all of them require access of data through different parts of the system. This is the nature of the public sector. The public sector is decentralized. And the big challenge in this public sector is that you are able to connect those different pieces of the system. Unfortunately, this problem, nobody was tackling it. It was almost the elephant in the room. Nobody was tackling it because everyone was only focused on his own little solution here and there. But I think today there is a recognition that this is what we need to do collectively, is to try to, and actually think about it. What's the impact of digital? It's about data. What is digital is good at is data. So if your data is small, the impact of digital is small. And if you really would like to increase the impact of data, then you have to solve this issue. So this is really the problem that no one was daring to address, and I'm glad that WHO and ITU now are very keen to solve it. How to solve the data issue? You need to do 3 or 4 things, that's all. And here I'm talking because we at ITU are also involved in other digital sectors, particularly on digital government. You need to solve 3 issues. You need to create trust, interoperability, and reference data. Trust, why trust is important? Because if the system doesn't trust each other, they cannot exchange data, as simple as that. So trust is ID, that I'm sure who you are. Trust is about consent. Trust is about trust services like e-signature and the like. Interoperability, like exchange platforms, whether system to system. This is the example of X-Road in Estonia, system to system, or system to people. Like, for example, I give my documents in digital format to be put in a digital wallet as verifiable credential. If you solve those, and reference data are the registries, basically. Everything in the health system and any sector needs to be uniquely identified with one source of truth. So if you solve those 3 things only, you almost solve the big nut to crack in the health sector. And this is the only way you reach digital transformation. How to put those capabilities? This is the DPI. So I'm trying to explain to you, DPI is for digital transformation. Innovation doesn't equal digital transformation. Digital transformation equals data. Data equals trust and interoperability. You apply trust and interoperability by your DPI. Why DPI? Because DPI is a shared platform. It's a shared infrastructure that really deals with the difficult things like the trust, like interoperability, like reference data. So what we need to do now? Let me be very honest from what I see in many countries. Here is the big problem in many countries. First of all, countries, let's face it, even in the digital government, not in the digital space, they don't have enough resources to build and to maintain many solutions, many platforms. Even if you give them open source, sometimes it's extremely difficult even to maintain open source. Many of the open source, and here maybe some people will disagree with me, but I think probably it's correct. Many of the DPGs, digital public goods that exist today, are built as monolithics. They are not built as building blocks. So if you are have goodwill and good interest to give a country a DPG, maybe you are give them a poisoned gift. I remember chief responsible of digital government in one of the countries. I told him, listen, we're going to give you open source. He told me, no, 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 I don't want this open source. How can I maintain it? Which is true. So how to solve this issue? DPI is the solution. How? Because we are breaking down, we are decomposing complex, big systems into smaller pieces. And if we are standardizing those small pieces, which we are calling building blocks, then, and if you make those building blocks available to everyone, that you are hiding the complexity and make it available for everyone. So me as a developer, I just need to build the front end and use the building blocks that are already available to me. And by the way, this is the approach that we are doing with GovStack. I think Garrett mentioned GovStack. GovStack is a joint initiative that ITU was one of the founders. And basically, we have specified the building blocks, their specifications, their open APIs, which is very important, and the architecture. And what we are doing today, you know what? We are working with countries on low-code, no-code platforms. Don't waste your time in building complex systems. Use simple low-code, no-code platforms, drag and drop to build the front end, because the back end is there. So if we are able to put the complexity and make all those difficult things that needs to be solved available for everyone, then it makes it very easy for local developers to develop solutions and being able to maintain them and scale them up without having to worry much about the back end. Garrett put a very good diagram for immunization. We are very good now, even the health sector, in identifying the requirements, and I think the digital smart guidelines is a very good example of that. We are very good in doing maybe the data now identification or standardization using FHIR. But we are not yet good in the back end. We didn't solve the issue of the back end. You can build very good solution, it looks nice, it is the right workflows, it is even the right data structures using FHIR, but designing how this will communicate in the back end, we are not there yet. That's why, and this is, by the way, I saw personally a very nice business. I was in Eswatini 2 days ago, and they showed that's a very good system, but it's just the front end. There is nothing in behind. I mean, you just get the forms, and then you treat them manually later on. So what we need is the reference architecture. The reference architecture, and this is the joint effort that we are committed to do with WHO and ITU. Why? Because when you put the reference architecture, you are guiding the whole ecosystem. Then no one provider, be it commercial or open source, can come and sell you their products, which happens today, unless it is complying with the reference architecture. And the reference architecture is based on reusable components and building blocks and APIs. If we only identify the APIs, only if we do this, we solved half of the problem. Because now the developers, even with simple tools, they can develop services that are quite complex because the complexity is already provided by the back end. So anyway, I think finally we are tackling the nut that we've been talking about 20 years ago, the interoperability. All of us talked about interoperability, but no one really understood how to solve it. And by the way, I'm saying identifying data standards is not enough. This is half of the issue. The second half is how to manage the architecture, how to manage the back end. And this is what we are hopefully going to come out with this conference, is to really work on the reference architecture. And we as ITU, we are very committed to work with WHO. But I'm glad that the narrative is very clear now, and I hope that we can do this very quickly, because if we have the reference architecture, this will help countries to shape the market, push the providers to adopt and adapt to the reference architecture. And by the way, even if the market is not ready, and you put a procurement with FHIR and architecture, the private sector will go and learn how to do those things. Even I would want to say to WHO, honestly, don't worry about capacity building too much. Why? Because worry about the requirements. Because if you put the requirements, I'm sure the private sector will follow. Just be clear. This is what we want. So I hope that, I mean, this give us, some good, some good push for the next 3 days. I think this is so critical. And if we don't solve this issue, I don't think that we can talk about digital transformation for health. Thank you very much.